I'd now ask Dr. Robert Matthew Reveille to begin his slide share. Dr. Reveille, we're so lucky to have him in our division and at the helm, leading us at the RMR VA as our division chief at the VA. He's ushered us through really an unparalleled couple of years, transitioning from our old location to our new location, and of course this COVID-19 pandemic. But we're excited to have him here today to really talk about one of his many passions, and that is diagnostic challenges in dysphagia. And hopefully he'll make the pill a little bit easier for us to swallow. Thank you, Dr. Reveille.
Thank you, Swati, and the committee for the opportunity to present a very difficult, challenging case. The title was plural, but this is such a complicated case. I think this is enough for a 20-minute presentation. Let me share my screen. Okay, can everybody see the screen?
It looks a little bit distorted, but try to advance and let's see if it populates the whole screen. There we go. That's perfect.
Okay, so I have no disclosures for this lecture. I'd like to present a case from our veteran population that resulted in a long course. And honestly, at the end of the case, I think you realize that all the faculty were involved in his care had a really tough pill to swallow. So this is a story of a 70-year-old male that 7 years ago presented to his primary care doctor with symptoms of dysphagia and regurgitation. He had multiple chronic medical conditions, including COPD, PTSD, as many of our veterans have, chronic pain, and osteoarthritis. His medication list included meloxicam, a variety of other medications for his medical conditions. And importantly here, as the discussion will unfold, he was not on any narcotics for his chronic pain. In characterizing his dysphagia, it was initially just solids and pills, and he typically would take a handful of pills and then would become obstructed. He noted frequent regurgitation. This was more pronounced toward the evening and nighttime, and he'd be awakened frequently by foamy saliva and food particles, awakened with cough in his throat. Now, he denied heartburn, but he did note that when he became backed up, that he had a vague chest discomfort that was really quite uncomfortable. Over time, and now I'm going to present a 5-year story here, over time, his solid food dysphagia progressed to liquid food dysphagia, and only recently did have the alarm symptom of weight loss. His PCP placed him on ranitidine, and without response, he was then escalated to a once daily proton pump inhibitor. He was then referred to GI, our group, for evaluation of dysphagia back in 2015. A series of diagnostic tests and interventions which took place over the past 6 years, including no less than 26 actual interventions and tests by our GI and surgical endoscopy colleagues leading into the present time. Interestingly, every time he had an intervention, he would have transient relief of these symptoms, only to have them return within a few months and prompt another visit to the GI group. So now, how do you think about esophageal dysphagia? This is really the crux of the biscuit here. In the absence of known risk factors, prior radiation, caustic injury, surgery for oropharyngeal disease, cancers, or known stricture, we move on down a diagnostic algorithm. And quite honestly, in a 70-year-old, we would expedite that because of the concern about an occult malignancy. The role of barium esophagography in the evaluation of esophageal dysphagia remains today still a controversial part in the sequence of diagnostic workup. And in his age group, we would move rather quickly down the right side of the pathway to upper endoscopy, looking for structural cause. And the structural causes would include things such as rings, webs, strictures, diverticulum, erosive disease, because GERD does cause dysphagia, tumors, infectious esophagitis, and related to Dr. DeLay's talk, also to rule out eosinophilic esophagitis. So we spend an extraordinary amount of time here on the left side of this algorithm. This encompassed most of the 5 years of his initial care. And once we dealt with this, what we really should be able to do is move forward to the right side of the diagram, where we talk about dysphagia to solids, and liquids, making us think about a motility disorder, and also extrinsic compression disease that an endoscopy might miss. And that's where the role of barium esophagography probably has its most important value. In addition, when you do barium esophagography and patient tells you that they have pill dysphagia, I think it's important to ask the radiologist to do a pill study. And they will provide a 13 millimeter tablet, which under normal circumstances should pass the entire esophagus and cross into the stomach unabated. So let's take a look at what we found on this individual. So this initial barium esophagram, there's a column of air and barium smoothly moving down the esophagus. There's not great motility, but it was read as normal, and the barium traverses into the stomach. What was interesting, and I cannot show you the video, but throughout this entire time, this 13 millimeter barium tablet seemed to float on top of the barium column, and he could simply not swallow this at all, and had to actually cough it up. He was referred for endoscopy 6 months after he saw his primary care, and his initial endoscopy, he had a smooth distal esophageal stricture. It was not at the actual anatomic GE junction, which is off in the distance. It was at actually 34 centimeters, and he underwent dilation. He had relief of symptoms. 3 months later, he returned for another endoscopy, and subsequent examinations and dilations were performed over the course of this 4-year period, and every time we had mucosal rents. Biopsies, I will say, were negative for eosinophilic esophagitis in the 7-year-old, which I think would have been an unusual primary disorder in this case. Ultimately, he was noted to have strictures popping up at different levels in the esophagus. In this case, this is a proximal stricture at 18 centimeters that required balloon dilation for, again, temporary relief of his symptoms. Almost in desperation, after 4 years of repeated endoscopy and dilations, the patient asked for an alternative, and our endoscopy therapeutics group said, well, why don't we place a stent temporarily? So seen on the right side is a coated esophageal stent that was placed for 3 months and had relief of dysphagia. After the stent was removed, a follow-up esophagram was performed, showing indeed no strictures throughout the esophagus, but an interesting abnormality of contractile activity in the distal esophagus and some narrowing across the GE junction. It did open, but it required tremendous pressure by the esophagus to open this GE junction. So what's the next step? Yes, high-resolution manometry. That's what we do. So normal high-resolution manometry is shown below. The catheters have sensors every centimeter and provide a 3D color contour profile of pressure and motion over time. I point out to the right here that as the color deepens toward the orange and red zone, that it represents increased pressure. And the background intraesophageal pressure is shown in a blue-green pattern. 2 points of esophageal manometry that are going to be critical in our analysis here. One is the attention to the gastroesophageal junction, or the EGJ. This is an example of the LES, which upon swallowing will relax and then close as the wave arrives in time. This is a normal high-resolution esophageal manometry tracing. Enter Chicago 4. Thanks to the great work by John Pandolfino and one of our former faculty, Rina Yadlapati, Chicago 4 has allowed us to further characterize disorders of esophageal motility using high-resolution technology. And again, 2 key points are as follows. Number 1, we focus on disorders of the esophagogastric junction because we can define them pathologically, and they have important implications for guided therapy and resolution of symptoms. The esophageal body then has secondary disorders of peristalsis, such as ineffective motility, often seen in chronic reflux patients. That could have been a consideration in this patient. However, you'll see in a minute that we were fooled and we learned something. So 5.5 years into this, we decided to perform an esophageal manometry. I was involved with his care, and I thought that it really didn't make sense that we were doing all these interventions and he was having persistent symptoms. So this is his manometry report, and I want to highlight some of the findings. The integrated relaxation pressure is a Chicago assessment of the ability of the lower esophageal sphincter to relax upon swallowing. And normal for the technology we use is less than 20. In this case, the IRP was in fact 45. The residual pressure was also elevated at 16, normal being less than or equal to 8 millimeters of mercury by the conventional criteria that I relied on for the past 30 years. The pattern demonstrated something we call panesophageal pressurization, which we'll see in a minute. Because reflux was also in the differential diagnosis, a pH probe was placed, pH impedance probe, and the pH results were actually normal. However, throughout the entire study, we saw frequent retrograde contractions and passage of the bolus, at times up to the throat, associated with regurgitation symptoms. So let's look at the phenotypes for achalasia, because now that I've let the horse out of the barn, I think what you realize is that we're actually dealing with a patient with achalasia. Type 1 achalasia really is the most advanced form of achalasia. In this example, the lower esophageal sphincter does not relax at all upon swallowing, and there is no esophageal body contractile activity. This is a very advanced loss of motor function in type 1 achalasia. In type 2 achalasia, the pattern recognition really is important here. In this example, the smooth muscle has lost function. However, the longitudinal muscle that invests the esophagus actually still has contractile activity, and upon swallowing, we see these longitudinal contractions and pressure-generated waves called panesophageal pressurization. And in type 3 achalasia, what we see is the distal esophagus is still generating extraordinary contractile activity, but it is non-peristaltic, that is non-propulsive. In fact, it can result in retrograde flow of bolus during the distal contraction. Importantly here, and as in his history, I mentioned no narcotics. 40% of patients who have this pattern of achalasia are on chronic narcotics. So the role of chronic narcotics in precipitating esophageal motor dysfunction, such as type 3 achalasia, needs to be kept in mind before you decide on therapy. This is our patient. I think everybody can appreciate that in each swallow, he had high amplitude, repetitive, and non-peristaltic contractions. In addition, along the thumbnails below, he had several contractions that looked more like type 3 achalasia. And as you can see to the right side, this actually correlated very beautifully with another picture from his barium esophagram, where the proximal esophagus was largely aperistaltic, and the distal esophagus had simultaneous contractile activity with an LES that failed to relax. So what we're dealing with is achalasia, type 2 achalasia of a long-standing duration, complicated by strictures. And in my opinion, the strictures were actually due to his meloxicam, which subsequently I changed to Celebrex, and it has no further problem. So what else can we do to diagnose this? Could we have diagnosed this early on and not waited 5 years to get to the point of high resolution manometry? Well, why not flip for it? So FLIP is a new technology we're defining a role for. It's called functional luminal impedance planimetry. There's a balloon bag that has sensors within inside to define, by using impedance technology, changes in conductivity along the balloon that allow us to define the diameter, intraluminal pressure, and what we call the distensibility index, or the compliance of the esophageal lumen, and specific attention to the gastroesophageal junction shown here. The balloon is straddled across the LES on the left, and this correlates very nicely with the compression that we see on the FLIP color tracing. Normal values for FLIP are as follows. A distensibility index less than 2.8, some investigators use 3.0, confirms EGJ outflow obstruction, of which achalasia would be the principal concern. Normal is 3 to 5, and if you do therapy on the GE junction for an obstruction, you'll see that the distensibility index goes quite high, and this is a very good target for all forms of therapy, including POEM, which I'll show you. This is our patient. We actually performed FLIP several months after the manometry results because of symptoms. On the left, you can see that there are no strictures. The sphincter is at this point right here, and there are these simultaneous contractions still being identified, as we saw on his manometry. Interestingly, with the FLIP in place, we also saw a very subtle low amplitude repetitive vertical contractions occurring in the setting of a very non-distensible LES. In fact, his distensibility index was 1.62. Voila, we have the diagnosis, we have a plan. Unfortunately, for this veteran, he's now had recurrence of a very aggressive bladder cancer. And so our plans for therapy, as outlined on the next slide, have had to be put on hold. However, we will have him back shortly to try to give him definitive therapy. The treatment of achalasia is definitive therapy and disruption of the LES. No matter what you do, the goal is to make that LES non-functional so that the patient can once again have swallow capability and hopefully reduce or eliminate the symptom related to regurgitation. Flip patterns for achalasia on the left. This is type 1. You see a very non-distensible EGJ and no contractile activity. A common pattern in type 2 achalasia is to see repetitive antegrade contractions and occasionally retrograde contractions, or over here, pretty much vertical simultaneous activity as we saw manometrically with this hypertensive non-distensible EGJ. In type 3, seen beneath here, is actually very characteristic of that vigorous achalasia pattern that we saw manometrically and we've described now for over 50 years. So what about treatment options for this patient? Well, over the years, we've done Botox, very in vogue, very chic to have Botox placed in your lower esophageal sphincter. We've done a lot of that. It's not a durable benefit, but some elderly patients seem to get benefit for up to 2 years. If you're not planning on other therapies, this is a reasonable option, especially in a very sick individual who may not have a good long expectancy. On the right is the pneumatic dilation. We place a long balloon, a rigid-flex balloon across the sphincter, inflated under fluoroscopically. The waste that's created on the balloon by the tight sphincter ultimately gives way, and you've disrupted the sphincter. To my knowledge, there are only 3 or 4 endoscopists in the Denver area that still are credentialed and have had any experience doing the classic form of pneumatic dilation. Perforation rates are as high as 5%, depending on the size of the balloon. And so we've tried to shy away from that in deference for surgical myotomy, shown here on the left. This is a laparoscopic Heller myotomy being performed, where the circular muscle and longitudinal muscle are incised through the diaphragm and down onto the cardia of the stomach, and then closed. And then often they will do a door or a fundoplication. I think the most exciting thing for the treatment of achalasia has been the introduction of POEM, or peroral endoscopic myotomy. In this example, the schematic on the left shows the endoscopist creating a submucosal tunnel through the distal esophagus, crossing into the crural fibers of the stomach, and then incising the muscle. On the right side, the tunnel is created. We enter the tunnel with a capped endoscope, and using saline, we expand the submucosa. And then once we've identified the muscle, we actually cut the muscle. This is an example of a beautifully well done myotomy. And on the right, closure. Can we use flip? Sure we can. This is the EasoFlip balloon, which is FDA approved. And in this case here, we did an example of achalasia dilation where we started with a non-distensible LES, and at the conclusion of the therapy, we have complete distensibility of the LES. And I think that in certain cases, this is an exciting and promising technique. So take-home points from this case. First of all, there was a lot of traction bias engaged by all the endoscopists at our center. And we should have thought earlier about several things. Number one is all strictures of the esophagus aren't caused by GERD. When you see strictures at multiple levels over time, look at the drugs that the patient's taking. Persistent dysphagia and regurgitation after management of structural causes should prompt a motility evaluation. High-resolution manometry using Chicago 4 is very valuable in classifying subsets of patients with disorders of the esophagus. There are a variety of endoscopic and surgical options for the treatment and relief of symptoms of achalasia. Remember, the target is the LES. And lastly, as we move forward into 2022, the role of flip. Flip is evolving as an important tool in both an early diagnosis of esophageal motor disorders causing dysphagia, and from my perspective, perhaps a new therapeutic option. Thank you for your time.
Thank you so much, Dr. Reveille. What a really humbling case to review with our audience here. Can't wait to talk about it a little bit more during the panel.